it's funny. I transitioned out of PQA in 2021, and I went back and looked at what the percentage of PQA's measures to the total star ratings program, where was
hmm
that when I left and where is it now? So
hmm
when I left, it was right between 20 and 22%. So the pharmacy measures in the star ratings accounted for 22% of the total star ratings. So essentially, it is more than double that right now. Pharmacy accountable clinical measures command the dominant weight of that program. And I think it's a game changer. I can't see how health plans are going to be able to step into this new environment
Yeah.
without doubling down on their collaborations and partnerships with community pharmacy.
hmm
So I think it's good news.
Welcome to the Pharmacy Quality Solutions Quality Corner Show. Buckle up and put your thinking cap on. The Quality Corner Show starts now.
Alrighty. Well, welcome everyone to the PQS Quality Corner Show. On today's episode, we want to celebrate PQA's 20th anniversary, representing 20 years of medication use quality and stakeholder engagement. We know many listeners may not be familiar with PQA as an organization. Some of you may, but for those who haven't, we'll give you a brief update so you know what we're talking about. And we're going to explore some of the history of PQA and talk about the highlights from the recent annual meeting just a couple weeks ago. I'm your host, Todd Sega, for today, Managing Director of PQS by Innovaccer, and I'm happy to have for this special episode the founding CEO of PQA, Laura Cranston, here with us today. So Laura, welcome back. It's been
Thank you.
several years since you've been here, so welcome back. Happy to have you.
Thanks so much. It's great to be back. It was good to see you a couple of weeks ago at that 20th anniversary celebration.
Yeah, likewise. Yeah, we enjoyed that. We're happy to have you back and would love to start with, of course, the background context that many listeners may be wanting to hear about if they're unfamiliar with PQA. So if you can kind of share your role in building PQA into what's established and what it's become, and then we can also, of course, get to the relationship between PQA and PQS, since I know it's very similar. One letter difference in the acronym often got switched up over the years.
Too
So
often.
we'll kind
Yeah.
of tease that apart here, but would love for you to kind of give some of that background as well.
Great. Well, again, thank you. And as many of you know, I had the honor and privilege of serving as the founder and CEO of PQA for its first 15 years. And PQA got its start in April of 2006, which was just a few months after the actual Medicare Part D prescription drug benefit kicked off for seniors. So it was very much the vision of the CMS administrator at the time, Dr. Mark McClellan, and his deputy, Lawrence Cocott, who had this vision of creating a multi-stakeholder alliance. I think I got the job, Todd, because I had spent probably close to 2 decades prior to that in healthcare association management, very involved with NACDS, National Association of Chain Drug Stores, and also involved with this organization called the Institute for the Advancement of Community Pharmacy. So when given the opportunity to take a founding role with PQA, I dove in with both feet, and it kicked off with actually no money. So it was a one-person shop for a good 6 months, and then it grew and grew, and it was one of those once-in-a-lifetime opportunities to really start something from the ground up. So I was really glad to have the opportunity.
Yeah, well, it shows you what the pressure does when you get back in the corner a little bit with the surprise of needing to create something from nothing,
Yes.
especially without funding. It goes to show how you need to leverage some of the relationships and the creativity to create that starting point into what it's become. So glad that it happened.
Yeah. And Todd, I would say we leveraged volunteers. So there were so many organizations. If you think about how many health plans are in the universe, in the Medicare Part D universe, there's quite a number of them. And when they heard CMS announce PQA, they all wanted to play a role in what that would become and how the measures were developed. So there was no shortage of committed leaders to help PQA get off the ground.
Yeah, and I bet it was just an exciting time with the unknown, but also having this new benefit roll out such that everybody wanted to get a little piece of that or to get in on helping to craft from the beginning. And I sort of think of it similar to AI, how anybody can kind of jump on that opportunity to learn more. And here we have the government paying for prescription drugs for the first time. Hey, that's probably important. It may grow into something. And if there's a passion and a true belief in what it is that someone or something is set out to do, it's not as difficult to find those who may want to volunteer to be a part of it. So obviously it was a very empowering concept that was crafted from the early point. So that's great.
Yeah.
So as PQA grew and laid its founding roots in measure use, the measure development, obviously there came about the PQS component of it for the solutions piece. So if you can kind of describe how PQS came about, that sort of takes us closer to where we are today, since that was a founding portion of this as well.
Yeah, so great question. And just a little historic context is, so PQA's initial focus was, let's develop a set of measures, okay? Measures that could be used for health plan accountability. And so as we're developing these measures, right, CMS keeps its cards pretty close to its chest. And so there was no star ratings program initially. That came a few years after. So we're developing measures, and I'm saying to myself, okay, are we going to give these measures over to CMS, and then what happens? And so what we decided to do when we had this initial measure set is we decided to fund a couple of pilot programs. In those pilot programs, we were going to see how they could use these measures to bring health plans and pharmacies into a relationship. We know that the patient, the senior, sees their pharmacist many, many more times, maybe 13 times a year as compared to seeing a doctor 7 times a year. So how do you bring the health plans working together with the pharmacy and this initial measure set? How do you give that visibility, and how do you evolve that into a value-based care program? So one of the 3 pilots, which was Rite Aid working with CE City and Highmark up in Pennsylvania, really looked like it had some legs. And they had developed a very simple platform at that time that would give visibility to how individual pharmacies in a network were contributing to the measures that were being used by for health plan accountabilities. And so that's kind of how it came together. And PQS, when we realized, PQS evolved from that pilot program, and CE City, who developed that healthcare technology platform, really evolved that platform to be a very, very robust platform. And even that evolved over time. And it was another startup, again, with no investors, just a group of very, very committed individuals who wanted to see it happen.
That's really fascinating to me, even hearing it, knowing I've been at PQS for a while. And I had a question that came to mind that I don't think I ever asked you about, so maybe the other listeners would hear about as well. I know, having been doing this for a while, that going to a payer or a pharmacy, but in this case, going to the payer, since the data origination source was the payer, getting someone to do more than what they're having to do is a tall ask. So if it wasn't a mandate, it wasn't regulated, and that's not saying anything disparaging with Highmark in the very early days, but I imagine back then it was still the same, where you're trying to do whatever you can with the resources that you have, and no one's looking around to find more work to do. So when you approached Highmark to say, we have this pilot idea, The measures aren't part of the star rating program, as you just indicated. What was that a heavy lift for that plan to say, sure, that sounds great, we'll do it? Or did it take some convincing? Like, what was it that they saw that they were willing to put resources into it when they weren't forced to do so at that point?
It's a great question. And I would say, everything was always trust the process, right? From developing the measures, which took a long time, we would say trust the process. And I think when asking and inviting a Highmark to partner with CE City and Rite Aid, again, it was trust the process. And in that situation, Todd, what I find fascinating, it was really the CE City who had developed a similar healthcare tech platform for providers. They had the vision and they really wanted to see pharmacy brought into that. So it wasn't just PQA selling someone on the vision. It was this healthcare technology company that had witnessed what was happening in the provider world that helped immensely.
That's interesting. I don't think I ever realized that distinction. So it's as if that picture was already painted in a different world, such that presenting to the payer this similar world of pharmacy allowed them to say, well, that already exists here. We see where it's going. That's not a stretch for us to think that we can't replicate that to the pharmacy world. So maybe it did seem more tangible to them at the time and something they could more easily get behind.
Yeah.
Okay.
Very much the case. And honestly, it was very funny. It was one of those back of the cocktail napkin discussions with the CEO of CE City at the time, who really was a visionary. And so when we decided that this had legs and it could scale, he was very excited to make it happen.
Oh, that's great. Well, it's the perfect mix of all the right scenarios between the organizations and the people. So, all right, well, that's good. Learn something new on the interview. So that's good. So as we sort of shift from, the founding portion of PQS, how that came about, if we go back to the PQA time in those early years, knowing that you had to create this with a team of volunteers and scarce resources, what were really the hardest things about those early years for the organization that perhaps you didn't anticipate when the ask came to do this daunting task?
Sure. So I think the heaviest and hardest thing was recognizing how long it took to get a measure from concept and ideation through the process. I really never appreciated how many steps in the process there were, from reliability testing, feasibility testing, gathering the clinical evidence to support that measure. And you add in all of those various steps in the process, and you're looking at 18 months to 2 years to develop a measure. And then, to be quite honest with you, CMS, in order to use a measure in a public-facing program like the Star Ratings program, it also not only had to be endorsed by PQA and go through PQA's process, but then we needed to submit it to an entity called the National Quality Forum and go through that endorsement as well. So it's kind of a dual endorsement process. And just, constant different timeline. So PQA had a timeline, then you get it through PQA, and then CMS said, oh, now take it through NQF. And it just it was very, very long. And then when you get through both of those, they say, okay, now steward them and maintain them and develop specifications. So it's, I had no idea.
Yeah, it kind of reminds me of the hiking analogy of getting to the false peak or the false summit. When you go for a hike and a 14er, you think you see the peak and you're like, hey, that's great. And you realize there's another one. And then you actually get to the real top and then you realize that you have to go back down. So there are a lot of similarities there, but it also makes me think of that expression of, if you want to go far, take others with you or join with others. And so PQA, being very consensus based, obviously had a large cohort representing different interests. And that made it perhaps more durable on the other side because it's pressure tested from so many different viewpoints. But at the same time, I'm sure that added additional time, but maybe that's also what makes PQA unique. So maybe if you can opine a bit on the measure development process in particular compared to other alliances that may have been tested inside the Beltway or outside of the Beltway, but how does that consensus-driven process sort of keep up in the world that you built?
Yeah, so ironically, Todd, I think back to the earliest days, and PQA annual meetings were where we would vote on new measures, and it was like having an open hearing. People could comment on the measure, they could try to shoot it down, they could express either their support or displeasure with that measure, and then everybody coming into the meeting was given a paddle, kind of like and at some point after discussing, debating that measure, you called for the vote and, yays, nays, and abstained. And you have to remember, we've always had life sciences around the table, and they actually always recused themselves of voting. Their legal team said you can't vote. So health plans had a vote, PBMs had a vote, community pharmacies had a vote, every other stakeholder. Life sciences listened intently to the discussion, but never voted. But where we were different is other alliances that existed in the market, they were trying to solve for something different. There was a level of dissatisfaction with how long it took for a measure to get endorsed. So all of these specialty societies were developing measures, cardiology, rheumatology, dermatology, etc. But they wanted to get them into the market faster. And NQF was, again, a process that was a little slow. And so these alliances were created to endorse measures for specialty societies and mostly provider level measures and health system level measures. And that's what they were solving for. They were never a membership-based organization. They were more loosely held. And probably 3 or 4 years after PQA started, all of those other alliances disappeared. And I remember some government officials getting a little nervous because government agency people saying, wow, this alliance went by the wayside, that alliance went by the wayside, and PQA remained standing, But I think we built an infrastructure that was pressure tested to last. So we were developing measures, but we were also doing these pilot programs and doing some research and then educating around the measures, whereas these other alliances came together simply to speed up the process for endorsement.
Yeah, it almost sounds as if the other alliances were like pop-up measure shops to solve the need, and then they sort of broke up and then and went back to whatever their priorities were, whereas PQA's model to be more enduring is to get the buy-in. And the buy-in is, hey, you need to be a member. So you've paid your membership fee, you're in, you want to contribute to it. It's not just a flash in the pan. And that allowed for this more enduring concept of developing new measures with broad consensus, but also maintaining a pipeline of new measures that the same process would be used upon. And when there's change, like a lot of these measures have new therapies that come out and GLP-1s that have different indications, you have to reevaluate that measure. So it sounds like PQA's process being more enduring here is to say, well, that membership society, while people may have come and gone, the organizations supporting it are still here, and they're happy to reevaluate and look at that measure, whereas some of the others that were really specific, they look around the table and say, who are we going to go to for a measure update?
Exactly. Yeah.
Okay. Well, it's been some time as we've gotten to where we are in 2026 and coming to this podcast episode, obviously hitting 20 years. So we just had the meeting that you alluded to up in Baltimore for their annual meeting. Were there any takeaways that came away from you related to a session or general themes reflecting on the 20 years from this last meeting that stood out to you?
Sure, that's a great question. And actually, the programming at PQA is very robust, and it's oftentimes difficult because they will run 4 sessions concurrently. It's often difficult to say which one to pick, in a certain time block. They had a number of interesting sessions this year, some on some of the new medication quality measures that are going to be in the display and the patient safety area. They had a patient perspective panel on refocusing the Medicare star ratings, which I thought was also very, very interesting. And then they had some sessions where you would have a health plan that's partnering with a community pharmacy network in an asthma management program specifically, or another disease state. And they would talk about what that partnership looked like, how pharmacies can help move the needle. So I would say there was something for everything, and also a lot of focus on AI-driven medication use and how is AI and technology going to play a role moving forward. Can't have any annual meeting these days without at least having a couple sessions dedicated to that. So yeah, no shortage of good content.
Well, especially if you look back probably over the last 5 years, at least the last 3 or 4 of that, there were some changes to the star ratings, but there wasn't an incredible amount of year-over-year change. And obviously you get a little bit of an advance notice with an advance notice of proposed rulemaking and then final rulemaking. So they never shock you to say, hey, we pulled this measure, added a new measure. You sort of know what's coming, but there was a lot this last time. So the meetings are usually a time to get some regulatory updates as well. That's sort of my segue to kind of bring up what I think is a really compelling value for pharmacy and payers to collaborate and work together. When you look at this last change on the final rule for 2027, there were so many administrative measures that were removed that a lot of plans, I think, counted on to comprise a weighted component to their overall or summary score. But if you add up this new weighting and the number of measures that hit for 2027, you start to do the math and you realize that while some may not be as directly impacted by a pharmacy, some can be indirectly impacted at a pharmacy or through pharmacists and their staff. But all of those measures that pharmacy can touch in some way, directly or indirectly, or influence, you're almost at 50% of a Medicare Advantage plan's overall star rating. So from where you sit and having watched the quality philosophy evolve, you never know, except for 5 o'clock on a Friday, for what CMS is thinking sometimes that comes out. But having been with CMS and worked with them and collaborated, especially from the early days to create PQA, does this structural shift in terms of pharmacy's role or ability to influence in the overall star rating represent sort of a hat that you can hang for what PQA was set out to do originally, that we dare say never would have existed without PQA? So curious to hear your thoughts on that.
Well, it's funny. I transitioned out of PQA in 2021, and I went back and looked at what the percentage of PQA's measures to the total star ratings program, where was that when I left and where is it now? So when I left, it was right between 20 and 22%. So the pharmacy measures in the star ratings accounted for 22% of the total star ratings. So essentially, it is more than double that right now. Pharmacy accountable clinical measures command the dominant weight of that program. And I think it's a game changer. I can't see how health plans are going to be able to step into this new environment without doubling down on their collaborations and partnerships with community pharmacy. So I think it's good news. And as the expression or adage goes, to whom much is given, much is expected. So I think there's a play here for pharmacy to realize that as these new opportunities may flow through,
in a post DIR world as well, it's a step up or get out sort of way to say pharmacy can be at the table here to influence and make a meaningful difference on quality medication use and help with these measures, because good work typically begets more opportunity. So the more that we can show pharmacy's ability to influence and engage on these measures, as more measures come into focus in the future, there may be additional plays, whereas pharmacy would have gotten passed up. So this is a good at-bat opportunity for pharmacy to show some serious engagement for where they can influence.
Yeah, and I would say one thing, Todd, so
Yeah.
when you look at the removal of 11 administrative measures and now this focus of being at an inflection point where you have pharmacy measures accounting for 50%, you also have measures, PQA measures, that are getting pretty close to topping out, where there is so little room for improvement that at some point CMS is going to have to likely retire those measures. And
Yep.
as they use that funky word they refer to, for example, adherence measures as intermediate outcomes measures, and CMS would love to get to true outcomes measures. They've also signaled that they'd like to advance the comprehensive med review measure, which is back this year. They'd like to advance that to, again, more of an outcomes-based measure, not a process measure. So I think this is a new direction, and I still think there's a way to go. So
Yeah.
I think 2027 will be very interesting, but I also think there's no turning back for CMS.
Yeah, I would agree. Well, let's, in our final moments here, maybe we'll reflect forward a little bit and into the crystal ball using those letters of AI and technology. And I think this world of pharmacy and the timeliness of the adjudicated claims is something that's always been an advantage for pharmacy compared to the medical side. So as we think about you looking into the crystal ball a little bit about the future of quality measurement and technology and these ECQMs, electronic clinical quality improvement measures, where we're extracting that data in a faster or more accessible way, and knowing pharmacy's data is quite accessible, do you see AI and technology shaping more of the data collected for measures, or do you see it informing because the speed to develop a new measure may be quicker, or is it a little bit of both?
Actually, Todd, I think it's a little bit of both. First of all,
Okay.
I hope that the speed to develop a measure is going to see some significant advances. I also think that when you look at how CMS has traditionally operated, there's a 2-year lag time. So they're using measures from 2025 that will inform the 2027 star ratings program. And I think we are going to get to a place where we move from this retrospective accountability and toward more proactive quality improvement. Wouldn't it be great to have an approach where we look at how we performed last quarter instead of 2 years ago? And so I believe that traditional measure development is going to evolve, and we are going to rely less on structured fields, and we're going to be able to extract clinically relevant concepts from unstructured fields of data. And that will allow us to do and develop measures that we can only dream about today that have not been able to become reality.
Well, it's an exciting opportunity to think about, because we know pharmacists are starting to document more clinically, whether it's services they're getting reimbursed for or platforms in which they can document various encounters that they're having, shared notes with physicians, et cetera. So, that paints, or those two opportunities sort of converge with how pharmacies are starting to evolve into that changing business model at the same time of how the measures are likely to change that you've talked about, to be more unstructured text, but also being able to predict and be more prospective about it. So, all right.
Actually, thank you so much for your time. But I also want to just say that's kind of the beauty of the PQS platform is your ability to refresh data and give health plans and pharmacies a look at their data, is more along the lines of where we hope CMS is going to get.
Yeah, I agree. That's where we're excited that aligns. We think we're positioned in a way to help advance that, but similar to PQA's founding mission, we want to do that in a consensus-based way with the payers that we work with, pharmacies that we work with, because we know that there's meaningful opportunity that exists that hasn't been tapped yet. And at the end, the patient can win through accessibility and greater services that pharmacists can provide. So we're happy to be one of the partners on the trail to help lead people to get there. So
yeah, and I'm glad that we had a chance while I was at PQA to partner with you, Todd.
Yeah, likewise. Well, we enjoyed it, and thank you for your time.
Yes, thank
certainly
you.
Appreciate having these conversations, and hope to have more of them. Hopefully, with a little less time in between our last gathering point to this one. But thank you, and then for those that are listening, thank you. We hope you enjoyed the conversation today, and you'll join us for the next episode of our Quality Corner show. And so before you go, we do have one final message from the PQS team. Thanks.
The Pharmacy Quality Solutions Quality Corner show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes. And we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.